I need you to stop what you're doing and listen very carefully to what I'm about to tell you. Because what I'm going to share in the next few minutes could be the most important thing you hear all year. It may even save your life, or the life of someone you love. I'm Dr. Vivian Coleman, lead cardiac health specialist at the Elders Wellness and Cardiovascular Institute, and a physician who has spent over 22 years operating on and treating patients over the age of 60. I've performed more than 14,000 cardiovascular procedures on seniors. I've held failing hearts in my hands. And I've stood at bedsides delivering news no family should ever have to hear. And I am here today because I am tired. I am tired of watching people die from something that was entirely preventable. Here's what they don't tell you when you walk out of your doctor's office with that little prescription in your hand. The blood pressure medication that millions of seniors take every single morning, dutifully, faithfully, exactly as prescribed, may be the very thing that is quietly, invisibly, systematically destroying the heart it was supposed to protect. I know that sounds impossible. I know it sounds like the kind of thing you dismiss, but I'm not a conspiracy theorist. I'm a cardiac surgeon, and the evidence I'm about to show you is sitting in peer-reviewed medical journals that your doctor has access to right now, and almost certainly has never discussed with you. For decades, we were told, take your blood pressure pill in the morning. Wake up, swallow it with breakfast, and you're protected. That advice has been repeated so many times by so many physicians on so many prescription labels that it has become gospel. But that gospel is wrong, and the cost of that wrongness is being paid in heart attacks, strokes, and preventable deaths, mostly in seniors over 65. In this video, I'm going to reveal the 5 critical ways that common blood pressure medications, when taken incorrectly, prescribed incorrectly, or combined with other drugs, are silently damaging the hearts of older adults. I'll show you the science. I'll show you who's most at risk, and I'll give you the specific doctor-approved steps you can take immediately to protect yourself. And stay with me. Because what I reveal at number 1 has already changed the way I counsel every single patient in my practice. It involves a landmark study out of Europe that followed over 19,000 adults for more than 6 years. The results were so dramatic that when I first read them, I had to sit down. A 66% reduction. I'll explain exactly what that means and why your doctor probably never mentioned it. Don't go anywhere. Now, I have a quick question for me. Drop a comment right now and tell me, how old are you and what blood pressure medication are you currently taking, if any? You don't need to be specific if you're not comfortable. Even just your age and the word yes if you or someone you love is on a blood pressure drug. We personally read and respond to every comment on this channel. Your experience matters. And what you share might help someone else who's reading these comments right now. All right, let's begin with number 5. Item 5, diuretics and the hidden electrolyte crisis. Thiazide diuretics. These are some of the most commonly prescribed blood pressure medications in the world. You may know them by names like hydrochlorothiazide or chlorthalidone. Doctors love them. They're cheap. They've been around for decades, and they lower blood pressure effectively. But here's what most doctors don't explain when they hand you that prescription. Diuretics work by flushing excess fluid from your body. That's how they reduce pressure on your blood vessels. But when your kidneys flush fluid, they also flush something else, electrolytes, specifically potassium and magnesium, 2 minerals that your heart depends on at the cellular level to beat in a normal, steady rhythm. When potassium drops too low, a condition called hypokalemia, your heart muscle becomes electrically unstable. It can begin firing irregularly. That irregularity has a name most seniors know and fear, atrial fibrillation. And atrial fibrillation, once it sets in, dramatically raises your risk of blood clots, stroke, and heart failure. A study published in the Journal of the American College of Cardiology found that seniors over 65 on long-term thiazide therapy were 27% more likely to develop clinically significant electrolyte imbalances than younger patients, and that those imbalances were linked to a nearly threefold increase in cardiac arrhythmia events. Dorothy, a 71-year-old retired librarian from Ohio, had been on hydrochlorothiazide for 9 years. Her internist had never once ordered a potassium level check. Her potassium dropped to critically low levels, triggering atrial fibrillation with a heart rate of 148 BPM. She spent 4 days in a cardiac unit that she never needed to visit. If you are on a thiazide diuretic, ask your doctor today when your potassium and magnesium levels were last checked. If the answer is, "I'm not sure," or "it's been a while," that is not acceptable. You deserve better. But the next item, it affects an even larger group of seniors, and the danger is something almost nobody talks about in the doctor's office. Item 4, calcium channel blockers and the silent swelling trap. Number 4, calcium channel blockers, amlodipine, felodipine, nifedipine. These are extraordinarily common. Millions of seniors are on them right now, and for good reason. They're effective at relaxing blood vessel walls and lowering pressure. But there's a side effect that most prescribing physicians mention almost as an afterthought, if they mention it at all. And in older adults, this side effect becomes genuinely dangerous. Peripheral edema, swelling of the feet, ankles, and lower legs. Now, most people hear swelling and think annoying, uncomfortable, a nuisance. They don't think medically serious. But here's the mechanism that makes it dangerous specifically for seniors. When calcium channel blockers dilate the small arteries in your legs and feet, but don't equally dilate the veins that return blood to the heart, fluid leaks out of the capillary walls and pools in the surrounding tissue. That's the swelling you see. But what you don't see is the effect that chronic swelling has on the skin, the circulation, and the lymphatic system over months and years. In seniors, this chronic lower leg fluid retention dramatically increases the risk of skin breakdown, venous ulcers, dangerous bacterial infections called cellulitis, and, critically, deep vein thrombosis, or DVT. A blood clot that forms in a swollen, under-circulating leg can travel directly to the lungs, causing a pulmonary embolism. That is a life-threatening emergency. Research published in the European Journal of Heart Failure found that seniors over 70 taking long-term calcium channel blockers had a 34% higher incidence of lower extremity complications, including DVT and cellulitis, compared to age-matched controls on other antihypertensive classes. Harold, 74, a retired electrician, 6 years on amlodipine. His doctor told him the swelling was just a side effect, harmless. One morning, Harold couldn't breathe. The blood clot that had formed in his chronically swollen left leg had moved to his lungs overnight. He survived, but required a week in the ICU and 6 months of blood thinners. The swelling from your blood pressure medication is not just cosmetic. It is a warning signal from your cardiovascular system. Take it seriously. If you have swollen legs and ankles and you're on a calcium channel blocker, ask your doctor whether a different class of medication, an ACE inhibitor, an ARB, might control your blood pressure with less of this risk. The conversation is worth having. Now, number 3. This one involves something that almost every senior does without a second thought, and it's creating a catastrophic interaction inside your heart. Item 3. The OAT drug combination that's silently spiking your pressure. Over-the-counter pain relievers combined with blood pressure medication. I want you to think about the last time you had a headache, a sore knee, a stiff back, or joint pain. What did you reach for? Ibuprofen, naproxen sodium, the drug in Aleve, maybe a product like Advil. These are NSAIDs, non-steroidal anti-inflammatory drugs, and they are some of the most widely purchased over-the-counter products in America. Seniors use them constantly for arthritis, for back pain, for general inflammation. They're sold in giant bottles at warehouse stores. They're considered so safe that most people don't even think of them as medications. But when you combine NSAIDs with blood pressure medication, you create a pharmacological collision inside your body that your cardiologist almost certainly has never fully warned you about. Here's the mechanism. NSAIDs work by blocking prostaglandins, chemicals in your body that cause inflammation. But those same prostaglandins also play a critical role in regulating your kidney function and your blood vessel tone. When you suppress them with ibuprofen or naproxen, two things happen simultaneously. First, your kidneys retain sodium and water instead of excreting them. That extra fluid volume raises your blood pressure, directly counteracting every milligram of the antihypertensive drug you took this morning. Your blood pressure medication is essentially neutralized. Second, NSAIDs cause your blood vessels to constrict slightly, adding direct upward pressure to your cardiovascular system. A landmark meta-analysis published in the British Medical Journal reviewed data from 40,000 patients and found that regular NSAID use raised systolic blood pressure by an average of 5 microcurrents in patients already on antihypertensive therapy. In seniors with already stiff arteries, that 5-point rise has been associated with a 15% increase in cardiovascular event risk. Margaret, 75, a retired school teacher with moderate arthritis. Her blood pressure had been perfectly controlled at 128/76 on her ACE inhibitor for 3 years. She began taking ibuprofen twice daily for knee pain, didn't call her doctor. 4 weeks later, her pressure had risen to 162/94. Her doctor, not knowing about the ibuprofen, doubled her medication. Margaret now takes 2 drugs where she previously needed one. If you have chronic pain and you're on blood pressure medication, please hear me. Acetaminophen, Tylenol, is a significantly safer option for most seniors. It does not interfere with blood pressure control. It does not counteract your medication. Ask your doctor whether it's appropriate for your pain. And now, I need you to stay with me, because the next 2 items are the most dangerous on this list. But before we continue, if this information has already changed the way you're thinking about the medications in your cabinet, hit the like button right now. It takes 2 seconds. And don't forget to subscribe and ring the bell so that you never miss a video like this one. This channel exists for one reason: to give you the real, research-backed information that your appointment time is too short to cover. You deserve to understand what's happening inside your own body. Now let's continue. Item 2. Beta blockers and the masking of heart attacks in seniors. Beta blockers. Metoprolol, atenolol, carvedilol. If you're over 65 and you have high blood pressure, there's a very real chance one of these is already in your medicine cabinet. Beta blockers are among the most prescribed cardiovascular drugs in the world. They work by slowing the heart rate and reducing the force of cardiac contractions, which lowers blood pressure. In many patients, they are genuinely life-saving. But in seniors, specifically those over 70, beta blockers carry a risk that is almost never disclosed at the point of prescription, and it is one of the most alarming things I have ever learned as a cardiac surgeon. Beta blockers mask the symptoms of a heart attack. The classic symptoms of a heart attack, chest pain, racing heart, shortness of breath, a feeling of impending doom, occur because your body responds to extreme cardiac stress with a flood of adrenaline. Beta blockers block adrenaline receptors. That's precisely how they work. And in a heart attack, when adrenaline should be screaming at you that something is catastrophically wrong, that warning signal is chemically suppressed. Seniors on beta blockers frequently experience what we call silent myocardial infarctions, heart attacks that happen without the alarm bells. No dramatic chest pain, no racing pulse, perhaps just a vague sense of fatigue, some mild shortness of breath that gets blamed on just getting older, or nothing at all. Meanwhile, cardiac tissue is dying. A 2021 analysis published in the journal Circulation followed 8,200 patients over 65 with diagnosed hypertension. Those on beta-blocker therapy were 38% more likely to have suffered a clinically confirmed silent myocardial infarction, discovered only during routine ECG testing, compared to those on other antihypertensive classes. In 62% of those cases, the patient had experienced no symptoms they recognized as cardiac. James, 78, a retired engineer on metoprolol for 4 years. His pressure was beautifully controlled. For 3 weeks, he felt off, more tired, less sharp. He thought he was fighting a cold. When he finally came to see me, the ECG showed clear evidence of a heart attack that had occurred approximately 21 days earlier. Permanent scar tissue had formed on his left ventricle. That damage doesn't heal. I'm not telling you to stop your beta blocker. For many seniors, particularly those who've already had a heart attack or who have heart failure, beta blockers remain critically important. But I am telling you, if you are on a beta blocker and you experience even vague, non-specific fatigue, unusual breathlessness, or just a sense that something feels different, do not dismiss it. Seek evaluation immediately. Ask for an ECG. Ask for troponin levels. These are simple tests. They take minutes, and they could catch a silent heart attack before it becomes a fatal one. And now, number 1, the most widespread, the most preventable, the one that is personally responsible for more unnecessary cardiac events in seniors than almost any other single factor. Item 1. The best morning dosing and the deadly 4 a.m. window. The timing of your blood pressure medication. I want you to think back to the moment your doctor first prescribed your blood pressure drug. They handed you the prescription. Maybe they explained the dosage, and almost certainly they said, "Take it in the morning." That advice, universal, standard, almost reflexive, has been repeated by physicians, pharmacists, and prescription labels for generations. And it is costing lives, silently, every night. Your blood pressure is not constant. It follows a natural circadian rhythm, a biological clock that governs when it rises and when it falls. During sleep, your blood pressure drops. This is normal. This is healthy. The body uses nighttime to repair, consolidate, and rest. But in the hours between approximately 3 a.m. and 6 a.m., your body begins preparing you to wake up. It releases a surge of stress hormones, primarily cortisol and epinephrine. These raise your heart rate, increase blood vessel tone, and drive blood pressure sharply upward. This is called the morning surge. In healthy adults, this surge is gentle and manageable. In seniors over 65, whose arteries are stiffer, whose vessels are less elastic, and whose cardiac tissue has been exposed to decades of daily pressure, this morning surge becomes a spike, a violent, destabilizing pressure wave that slams against already weakened arterial walls between 3 and 6 a.m. The early morning hours represent the single most dangerous window for heart attacks and strokes. The incidence of acute myocardial infarction is between 40% and 70% higher in the hours between 4 and 8 a.m. compared to any other time of day. Now, here's the problem with morning blood pressure medication. Most blood pressure drugs have an active window of 12 to 18 hours. If you take your medication at 7 a.m., its protective effect begins waning by 17 p.m. By midnight, it is significantly diminished. By 2 a.m., 2 hours before the most dangerous cardiovascular window, for many patients, it is effectively gone from the bloodstream. You are medicated during the safest hours of the day, and you are unprotected during the most dangerous ones. The pharmaceutical industry knows this. Cardiologists know this. And yet, because there is no money in changing a dosing schedule, because it doesn't generate a new prescription, because there is nothing to patent in the phrase, "take it at bedtime," this information has not made it into routine clinical practice. In 2022, the European Heart Journal published the results of the hydrochlorothiazide trial, one of the most comprehensive cardiovascular studies ever conducted. researchers followed 19,084 adults with diagnosed hypertension for an average of 6.3 years. Group 1 took blood pressure medications every morning. Group 2 took the exact same medications at bedtime. Same drugs, same dosages. Only the timing was different. The bedtime dosing group had 45% fewer major cardiovascular events, and their risk of dying from a cardiovascular cause dropped by 66%. 66%, not a modest improvement, not a marginal benefit. 2/3 fewer cardiovascular deaths. By changing nothing but the time of day, a pill was swallowed. When this study was published, it should have been front-page news on every newspaper in the country. Every cardiologist should have immediately contacted their patients. The FDA should have reconsidered label guidance. But that didn't happen, because there is no financial incentive to make it happen. George, 73, a retired postal worker from Nevada. He walked 3 miles every morning, took his blood pressure medication every day at 7 a.m., right after breakfast for 12 years. One Tuesday morning, his wife found him unresponsive at 5:30 a.m. He had suffered a massive heart attack between 3:30 and 5 a.m. His 24-hour blood pressure monitoring showed readings of 182/108 between 3 and 6 a.m., completely unprotected. George survived, but uses a walker now, cannot climb a single staircase, no longer drives, not one person, not his primary care physician, not his cardiologist of 8 years, not his pharmacist, had ever mentioned bedtime dosing. That is not an oversight. That is a failure of the system. Here's what I want you to do this week. Make an appointment, sit down with your doctor, and ask specifically, based on the hydrochlorothiazide trial published in the European Heart Journal, would bedtime dosing of my blood pressure medication be appropriate and safe for me? Write that down. Say those words exactly. The hydrochlorothiazide trial, European Heart Journal. So let's bring this together. We've covered 5 ways that common blood pressure medications may be damaging senior hearts silently and unnecessarily. Thiazide diuretics that quietly drain the electrolytes your heart depends on. Calcium channel blockers that cause dangerous lower leg swelling that progresses into clotting risk. Over-the-counter pain relievers that directly counteract your blood pressure medication and drive your numbers dangerously upward. Beta blockers that mask the warning signs of a heart attack, turning a survivable event into a silent catastrophe, and the devastating data-backed crisis of morning dosing, leaving seniors completely unprotected during the exact hours when the risk of dying from a heart attack is highest. These 5 issues, taken together, represent a pattern, a systemic pattern of information that exists in the scientific literature, that is accessible, that is actionable, and that has not been communicated to the people who need it most. You are not too old to change this. Your body is not beyond protection. The heart is a remarkably resilient organ. I have seen patients in their 80s make changes to their medications and their habits and dramatically alter their cardiovascular trajectory within weeks. You are not a passive recipient of whatever prescription pad gets handed to you. You are the most important advocate for your own cardiac health. And now you have the language, the evidence, and the specific questions to walk into your next appointment differently. The seniors I watch thrive, the ones who remain sharp, independent, and vital into their 70s, 80s, and 90s, are not the ones who simply follow instructions. They are the ones who ask questions, who challenge assumptions, who refuse to accept "these things happen" as a sufficient answer. Every morning you wake up knowing what you now know is a morning with more power in your hands than you had before. Every conversation you have with your physician, armed with this information, is a conversation that could redirect the trajectory of your health. And every day you act on what you've learned is a day your cardiovascular system gets closer to the protection it has always deserved. Do not let another night pass with your heart unguarded during its most vulnerable hours. If you have questions, about your specific medication, about how to talk to your doctor, about anything we covered today. Leave them in the comments below. I read every single one. I respond to as many as I can, and your questions help me know what to cover in future videos. If this video gave you information that no one else has bothered to give you, share it with your spouse, with a parent, with a sibling, with a friend you know is managing blood pressure. One share could start a conversation that saves a life. Thank you for watching. Take care of your heart. It has been working for you without a single day off for your entire life. It's time you worked for it.